This is the Rethink Podcast, where we talk to people who challenge the status quo and who are reshaping, reigniting, and rethinking the economy through health innovation. Please welcome your host, Sanj Singh.
Welcome, everyone, for another episode for the Office of Health Innovation and Economic Development, OHI. Today, we've got a special guest here with us, really talking about how do we transform primary health. This is something that's been a hot topic in the media, amongst the healthcare workers, and of course, which I believe the patients and the consumers who are going to drive the need for innovation. So today we have guest Dr. Hanif Chaur from New Brunswick, and I'm going to get him to introduce himself, and also right here from Saskatchewan in Regina, Tom Douglas, who's the CEO of Lumeca, and he'll talk a little bit about what they're doing from a software perspective and some of the clinic ideas we have. So I want to welcome both of you to the podcast. And Hanif, and Tom, what I'm going to do is, before I get you to, I'm going to get you to do the introduction, and I like to kind of set the stage and kind of provide my perspective from as an entrepreneur as well, working in the healthcare field, at least on the drug and diagnostic development side, but also now we're going to be owners. My brother and I, who's a surgeon, after our dear mother passed last year, she left a healthcare facility here, which has now been converted into the first nurse practitioner-led primary health center in Saskatchewan, which we're proud to do and support. So Hanif, I'll turn it over to you and welcome. And again, thanks for taking the time to be here today.
Thank you so much for having me. So I'm Hanif Chaur. I'm an emergency room physician and CEO of eVisitNB. Live in rural New Brunswick, and super excited to talk about how digital health and innovation can improve not only access to healthcare but outcomes, and drive real value to citizens. So super excited to be here and to share my thoughts.
Great.
And he's being modest. He's also past president of the college in New Brunswick. He's also an emerge doc. This guy is always busy, no matter when I get a hold of him.
Always have time for you, though.
It's interesting. Tom was and I were on a call with Minister Hindley a few days ago, and he was talking and let's say championing a lot of things that I am working on. And I did say, listen, I like to temper his enthusiasm. I'm not Moses parting the Red Sea here. We're just trying to do our small part to make a difference and in the areas that we can, right? It's a big system. It's a big complex system and a lot of moving parts. But with that said, Tom, I turn it over to you to introduce yourself for our audience today.
Sure. Thanks, Sanj. Yeah, it's awesome to be here. And I mean, I think people would think it was weird if I wasn't a passionate orator with the name like Tom Douglas or Tommy Douglas in healthcare. They'd probably be a little set back. I'm just trying to live up to expectations. But so I come from automotive. I'm the tech entrepreneur who just wandered into healthcare. So kind of looking at things with a fresh set of eyes. I've been with Lumeca since the start of the pandemic. Before that, I built a tech company in automotive right here in Regina. And it was a software company, and that's what brought me over to Lumeca. Lumeca was originally a clinic, a lot like eVisitNB, delivering care. But the owners, the founders, knew that it was going to be an uphill battle. There's a lot of red tape, and that a viable path for us was to turn it into a software company. So that's why they brought me in, and that's what you see behind me there is the Lumeca software, which is the clinic that became the software company.
This is great, Tom. So let me just start off with this because I want to dive into Hanif and what you have done in New Brunswick and also what Tom is championing here with his company, and also some of the virtual clinic ideas that are nurse practitioner led. But let me offer some thoughts here to maybe provide context for our audience as well. People talk about innovation. And in healthcare, innovation is something that can take on a couple of parts. One, a lot of innovation. I even spoke to somebody within the health authority. I'm not going to mention who. I asked them, "What is your definition of innovation?" And they said, "Well, outsourcing laundry service." And so maybe in their mind, in their day-to-day work, they saw that there are some efficiencies or some pain point that is being addressed by outsourcing, laundry service. To me, if you're going to have disruptive innovation in health, one thing you have to understand, and this is my perspective, and hopefully this is some of the maybe the background or backdrop, for Hanif, what you've experienced as an emergency room physician, is the complexity of the healthcare industry. It's just, when people talk about healthcare, if you talk to 10 people, ask them what their definition is, most of the time they think about just hospitals and doctors. And yet there is so many other moving parts to this. And so to try to innovate within a complex system that is interrelated becomes a real challenging issue, especially with changing mindsets, number one, because people are so used to doing the things that they do. And sometimes that identity gets challenged when change comes about. And then at the same time, adopting something that is scalable across the whole system, that actually will deliver and maybe democratize care in such a way that it addresses some of the big pain points and some of the bottlenecks that people are experiencing these days. And I think the COVID pandemic, if it didn't exacerbate the situation, it sure put a spotlight on it of maybe a underlying issue that had been there for many years, but just people were ignoring it when they couldn't anymore. So I was really when Tom brought this up, I said, hey, you got to talk to Dr. Chaur out in New Brunswick and see what he has managed to do. You have managed to address, it seems like, these types of challenges that are so hard to implement, and you've got the government on board paying for it, which, in the drug and diagnostic development business, the U.S. is the biggest market for us. The first questions a lot of investors and even strategic partners ask is, hey, what's the reimbursement environment going to look like? What's going to be the clinical outcomes? What's the patient outcomes? And how's that going to impact the pharmacoeconomics and, blah, blah, blah. So, with that, you may agree or disagree with some of that, but those are some of the factors that I see. And when I looked into the eVisitNB, it seemed to address a lot of these things. So I got to congratulate you on navigating through all of that and iterating probably many times to get to where you did. So, with that, I'm just going to turn over for you to talk about, what you've created there. What was kind of the catalyst and the drivers? And, what were some of those, let's say, suasion techniques that were used to bring all the parties together? And then how do you see that, translating going forward and what we could do in Saskatchewan, for example?
Well, that was very eloquent, and I agree with you. So I'm kind of watching a show right now called The Three Body Problem. It's really popular on Netflix. But the long story short is that we've got a three body problem in healthcare that sometimes feels impossible to solve, and you've got one body, which is massive, and that's patients. You've got another body with that's equally massive, which is the providers in healthcare, physicians, nurses, nurse practitioners. And then you've got a third body, which is a payer, and the policymakers, which is government. So in the US, you're talking about, insurance. So, and you've got healthcare, which is this planet that's trying to get a stable orbit around these three bodies with competing gravitational fields at sometimes. And when you do get alignment, like we have right now today with eVisitNB, you get a period of what I call stability, where you've got the payer, the providers, and the patients all aligned, and it doesn't happen often, but when it does, you can get an incredible amount of growth, innovation, adoption, and it's really a period in which everything is flourishing. So this is what we're talking about all the time: is how do we get this three body problem and solve it? And I think when I look back to, my frustrations as a provider, as an emergency room physician, I have an emergency room that is not really engineered to work best for me. what do I need to thrive here, whether it's culture, resources, etc. And if you were to ask my patients who are waiting in the emergency room in their uncomfortable chairs with no water, sharing a single bathroom, essentially experiencing the ER exactly the same way they have for the last 50 years, I think they too will agree that this is not an environment in which is really kind of engineered for them to really get what they need. So we've got a healthcare system that's not working for providers. I think if you surveyed most nurses, doctors, nurse practitioners, they'll tell you that the system as it's currently structured is not necessarily one in which they want to work. That's why so many of them are leaving, either for other markets or opportunities, or are actually moving themselves completely out of healthcare, by early retirement, as well as pursuing things in private sector. And unfortunately, our patients have nowhere else to go. So they're left often with less and less. So, and our payers don't seem to have figured out that, if we create a solution where providers want to work in and patients want to go to, then, you essentially have healthcare that works. And that's what that essentially was the genesis for eVisitNB. How do I create a platform where providers want to provide care? In other words, I've created infrastructure that allows them to practice medicine, give them the resources and the tools that they need, and also make sure that patients are able to access these. One said to me, "Wow, I can finally make an appointment with the doctor online. I've been able to do that for my haircut for years, but I have to call 100 times to talk to my family practitioner." So, so we're finally catching up. So I think this three-body problem that you described, I think we managed to align our payer by actually first solving for our providers, creating a infrastructure where they wanted to kind of deliver care, as well as, of course, patients, and being able to kind of engage with the platform digitally and conveniently from their home. And the pandemic, of course, was the accelerant that allowed for mass adoption. So I think that kind of summarizes the story in terms of how we got to where we're at today. But I think that the magic really happened when citizens started kind of going to, their legislative bodies and members and saying, "There's this platform out here and it's really making a difference. I don't have to go to the emergency room to get my dental pain looked at. I actually can get it done online, and I don't have to expose myself to the virus. I'm not taking up services in the emergency room, and why can't I pay for this with my Medicare card?" And there was kind of this epiphany that happened in government, because they too are human beings and they too want to access healthcare services outside of our emergency room, and they too have pain points like UTIs and dental problems. And when you had these individuals and their family members starting using eVisitNB and recognizing that, yes, this is indeed something that can work and should be available to all citizens, that's when we started having these conversations and saying, how do we take this system that works and allow it to be scaled to allow all New Brunswickers to have access to it? And of course, that brought its own challenges. So,
yeah,
like a eureka moment.
Yeah, I want to take you back to when you talked about an environment where providers wanted to work. As Tom said, you were president of the New Brunswick Medical Association.
Yeah, the College of Physicians. The regulator. The College of Physicians and Surgeons.
To the regulator. Sorry. What is it that the providers, and how did you get them to rally around this? And what is it that was really the most important to them in terms of, let's say, that created that sticky web for them to say, "Hey, if you can do this and this, I'm in," right? Because that sometimes is just growing up in a medical family, you spend a lot of time with doctors. And I remember even talking to my brother who's a surgeon, and I asked him, I said, "Why are you guys so difficult as surgeons?" And he said, he goes, two reasons. He goes, number one, he says, not that we're difficult. He said, if something goes wrong in the OR, everybody looks to me to solve it. And ultimately, I am responsible. So he goes, that's number one. And he goes, and the second thing is, the way I do it is better than the other surgeon. So it's,
agreed.
So how is it that you were able to bring together a group of people that I know have their own ways of doing things
Right.
to kind of rally around a common thing. That is in itself is remarkable.
Yeah, I think,
Maybe Hanif, before you jump
yeah,
in on that
sure.
one, I was just going to say for the listeners who don't know what eVisitNB is in terms of scope and size, maybe the quick stats.
Yeah.
It's about 50 nurse practitioners. Is that still around your
Yeah.
amount of providers?
Yeah.
About 500?
Yeah, so we're close to about almost 200 nurse practitioners,
Wow.
and we provide care on average to anywhere from 800 to 1,000 New Brunswickers a day.
You
And
doubled.
yeah,
Wow.
and we hold about 230,000 charts in the clinic. So that's how many patients we have, and we're growing at about 200 to 300 new patients a day. So a
The
fairly
market is speaking. The market is speaking for itself.
Yeah, the
Yeah,
patients are
so
voting. Yeah.
yeah, and I think that, so I think kind of going back to your question, so one is that, providers did not, we had to create a new model of work. So everybody wanted to help. And right now, when you look at primary care practitioners, they're probably not, they're saturated. They're doing, I don't know anybody that's twiddling their thumbs or has their feet up. I look at my family. I have to walk really fast if I want to talk to a family doctor in the hospital. Okay, nobody's strolling. These individuals are on the move all the time. They're servicing the needs of their patients in the hospital, in the clinics, etc. So I had to look somewhere else. I had to say who's got hidden capacity in the healthcare system, primary healthcare system. So I went to nurse practitioners. I happen to be fortunate enough to have trained one back when there wasn't a lot of nurse practitioners in the community. So I trained a nurse practitioner in our emergency room for their kind of urgent care services. And I was really impressed with their approach, with their knowledge base. And so I went out and I said, look, how do you work? What do you do? And for me as a physician, there's always more work for me to do. I can pick up an extra shift. As a family doctor, you can you can work an extra afternoon, you can see more patients in your day, you can run into the evening. But the economics of the way nurse practitioners were structured is that they typically tend to be salaried employees with a finite day with no capacity to work more. Yet some of them wanted to. So in other words, I was like, wow, okay, you want to work more, but your entire the economics don't allow you to do that. There's
Stuck
no
on
ability.
salary.
Stuck on salary, and there's no way to even do overtime. And what was really interesting, I said, why didn't you just pick up a shift as an RN in the hospital? You can't. You're actually classified completely differently. So you can't just work backfill as a nurse because of all these kind of regulatory requirements. I said, what a great opportunity. I said, what if you could do, like if you had 20 minutes at lunch, what if you could pick up an appointment? What if you wanted to just do a little bit in the evening because you had some free time? What if you didn't have to give us blocks of time or shift? What if we created a model in which if you had an opportunity to deliver care, whether it was for a UTI or a mental health problem or whatever is put in front of you, and you wanted to pick it up because you had the time to adjudicate that and it worked for you, you can just swipe and pick it up. And so I said, what if we use the Uberification of work? What if we could micro harvest time from hundreds of nurse practitioners who wanted to give us 20 minutes here, an hour here, 40 minutes here, and actually present to them a case and also make sure it matches up with their interests and competency? Maybe you can create a win-win environment. And so this Uberification of work was already being kind of used extensively by many companies. You were using this with your virtual waiting room. Maple was using it with their kind of one-to-many system. Somebody comes in, first person to pick it up adjudicates it. So that's the model we adopted. We ended up getting into a licensing agreement with Maple, using this Uberification of work, staffing it with nurse practitioners who wanted to do more and had the capacity to. In other words, they were kind of constrained in their primary care practice, but they wanted to contribute at lunchtime, before work, after work, and on the weekends, and really set up this kind of model in which people could give us whatever they had in terms of primary care. They could actually only pick up the cases that they wanted, and ultimately patients would have a place to be able to digitally access care through video, phone, text messaging, and we tested it and it worked. And I think what the pandemic gave us and what family practice gave us, what specialists gave us, is that they realized that there's an 80-20 rule like most things, and 80% of the time, a lot of medical problems can either be investigations can be initiated, or the whole process can be adjudicated digitally, and 20% of the time you really need that in-person assessment. So, moving to a digital framework allowed us to have, New Brunswickers access us in a timely fashion and get at least 80% of the problems looked after, recognizing that healthcare still requires you to have an in-person assessment about 20% of the time.
Well, this is, I mean, the market is speaking, right? I mean, so I think the one thing that even though people consider healthcare as public good in Canada, the market does speak
Yes.
in this case. And Tom, when you came across Hanif's work, how did you? I mean, I know you're excited about this and you're championing this, but talk a little bit about Lumeca and some of the projects that you're working on right now. And I saw the news release on the messaging app. I was just talking to Dr. Jenny Basran the other day. She said, "I love it. It's great. This overcomes one of the biggest problems that physicians had with not being in front of the privacy commissioner." And by the way, my wife was the privacy officer in the access for the health authority, so she used to deal with a lot of the physicians doing it on text. But what they were really trying to drive towards was getting better better care, like how quickly, efficiency, and they're just using the systems that were in place because they were frustrated with the types of infrastructure that was there. But talk a little bit about Lumeca and what you see the opportunity with Hanif's model and what you guys are doing with Lumeca against Saskatchewan and abroad.
Yeah, I think it's really interesting because if you go back to the start of the pandemic, you have two very similar clinics, right? You have eVisitNB, but it's staffed by nurse practitioners serving the general public. There's the drive from COVID to do more virtual. And you had the Lumeca clinic, which at the time was staffed by physicians. It's a walk-in model or same-day access. And both of them, it's the same thing, that 80-20 rule. You've got to have partners to send people to. You got to be able to talk to those partners in the community, say, yeah, this person needs to be seen in person. Can you handle this, and be able to communicate with those. The difference, the interesting part, and maybe Hanif's just a better lobbyist, who knows? But with physicians, it was really hard to deliver virtual care economically. The economics didn't make sense for physicians. And you said it at the start of the call, Sanj, like sometimes it's really hard to innovate in legacy systems. There's so many rules around physician fee codes and billing and what they can do, really hard to innovate. Whereas Hanif, working over there in New Brunswick at NPs, seeing all this extra bandwidth and not having all this legacy stuff to work with NPs, you were able to build from scratch. And the patients on both sides love the service because when you go from no access to care, it's a huge difference for those patients. Like I was reading a study out of Ontario done on a hybrid model of care. I think it was to do with patients in the forces. And the cancer screenings went from like 6% to 40%. Breast cancer, the screenings more than quadrupled. And these people, or have access to care. Like in the Lumeca clinic, 80% of our patients didn't have a family doc. So it's a lot like Hanif, the story you tell, you have the two family doctors who quit in your community, and now they're all coming to see you in the emergency department. And that kind of was the eureka moment for eVisitNB. So for us at Lumeca, when we realized that, the fee codes was a really complex system to operate a clinic, but virtual care as a platform was not going anywhere. Much like the sort of .com bubble. There's all these companies in the space at the start of the pandemic. There's all these virtual care companies. And then there's, a consolidation phase after. Both, took two different paths, but both found sort of winning avenues. Hanif, you found an amazing niche using this extra resource, this extra slack in the system, so to speak, and redeploying it. And Lumeca on the other side, we realized virtual care is not going anywhere as a service. And so what we've been focused on building is how do we make it efficient? How do we enable the brick and mortars to do it more efficiently? And one of the biggest problems we found was that healthcare is so siloed and so limited in modes of communication, that it slows down care. So that's what, you mentioned there, Sanj, the newest product. It's basically WhatsApp for doctors. The doctors are doing it already. They're texting all day long. So why not give them something privacy compliant? But I'll be singing Hanif's praises, for years and years to come, because there's just so many reasons why his model works better. But my big question, Hanif, for you, nurse practitioners, obviously, they've got the extra resources, which makes them a good fit. But how do you make them get along with physicians? You're a physician yourself. You mentioned training them, but there's this sort of turf war a little bit that's always existed. How do you make those two work together? Like, how do you see nurse practitioners fitting into like the not just virtual care, but primary care as a whole?
Yeah, no, it's a great question. I think that anytime you've got, two providers or groups of providers kind of providing the same care to that cohort of patients. So I think that, there's no conflict inside the organization itself, right? So we've got nurse practitioners that provide all the care, and then we've got medical directors which act as resources for these nurse practitioners, because we talk about healthcare access. Now, virtual care is fantastic, but what we find is when you've got kind of, when you've got the level of access that you do to eVisitNB, and there's almost limited to no access to healthcare for some patients, sometimes people kind of come to us for problems that are not necessarily suitable to be adjudicated virtually, or they're really complex because they're complex patients. They're either because they grew old with their family doctor, but now their family doctor's retired and they're coming in with all these health problems. So the first thing we need to do with nurse practitioners inside eVisitNB is give them all the support they needed from, individuals like myself with an MD, and also other medical directors that they can reach out to, from 8 in the morning till 10 at night. So we get complex patients, and working in, we talk about siloed healthcare, digital health, all these individuals are not practicing. There's no opportunity to have a hallway consult, to simply go and talk to my, I talk to my emergency room colleagues all the time, or if I see a surgeon, I might toss a case by him, that's, so I can get some perspective. But my digital health providers don't have that. So we have in-app messaging that allows them to talk to each other, but more importantly, they can reach out to the medical system or to medical doctors, and we can support them adjudicate these complex cases. And more importantly, the majority of our providers, so 75% of our providers do not reside in New Brunswick, and the advantage to that is you don't, because we're taking care of you digitally, you can actually reside anywhere else in the province. We do ask that you get licensed in New Brunswick and in the province of your residence, but we can take advantage of time zones as well, which allows us to be a lot more efficient well into the evening without exhausting our New Brunswick pool, asking them to work until 10 or midnight. But just digressing a bit, the key to successful collaboration is communication. And so, the key is when you've got your patient coming to our platform, and we're initiating a series of labs, investigations, or changing therapeutics, it's critical that we communicate that to the patient's primary care provider with the appropriate consent. And as physicians continue to see the great work that's adjudicated on the platform for their patients when they're not available, it's really great to have a patient tell us, well, I picked up the phone and my family doctor was out of the office today. They were ill. They had the flu, but they left on their message to access eVisitNB because we're going to be able to look after you when you're not there. And you can't expect even team-based primary care to be available for you 24/7, 365. It's just not reasonable. Yet patients need access to care outside of our emergency rooms 24/7, 365. That dental pain, that UTI, those set of hives, or that skin infection, whatever it happens to be, needs to be addressed now. So, we support primary care, we communicate with primary care, and I think if you show your work, you improve the trust with primary care, and I think that's where you build kind of lifelong systems. You help each other, you communicate, and that just organically turns into collaboration. So I think there's going to be apprehension because it's the unknown, but I think that if you set up a system in which you're showing your work, you're supporting those patients, you're sending them back to their medical home, and when they do arrive there, you've kicked off on some therapy, or maybe those investigations are available to the family doctor, and they can now adjudicate the visit, in that appointment rather than bringing them back over multiple appointments. I think they start to see how this can work, mind the gap for their patients when they're not available. So I think the key is good communication, show your work, that organically turns into collaboration. And pretty soon you have family doctors saying, I couldn't find a locum. I'm away this week. I'm off to see my kids or, take that much needed vacation. But I'm going to advise my patients that they can go to eVisitNB. They can get their needs met because they know when they come back, they're going to have good communication. They're going to be able to pick up that ball and continue with their patients, but their patients are not going to have to go to the emergency room or go without. So that's how we've done it here. And I think it's working well. It's taken a long time, but I think trust does. I don't think it's instantaneous. So that's how we've done it, and it's working well.
Yeah, I think it's moving towards seamless integration and communication is what you're addressing. And just looking up the square kilometers of New Brunswick is 73,000, and Saskatchewan is 660,000. So when you have the opportunity for scaling a technology that is agnostic to geography, and you're providing, let's just say, a movement towards universal access.
Yeah.
I mean, it's the pursuit, right? I mean, I think one of the things I really want to get into here is you talk about patient-centered care, but really, there was a adage in corporate philosophy that the best way for shareholder return is that, number one, you look after the customer. Secondly, you look after the employees. Third, you look after the community. And if you do those three things, the shareholder return should be there, and you're running a good corporation with good governance, good environmental, social types of just mindset and policies. One of the things that I'm curious now that the adoption has taken and given the number of patients, over 200,000 that you've charts that you have, what was the education level that has increased amongst the patients? Because sometimes, where should they go to emergency? Should they go here or there? Has the introduction of this service started to get the individuals a little bit more involved and educated in their own managing their own care rather than just automatically defaulting to, well, I'm going to go to Emerge and I'm going to demand being seen in Emerge. I remember my brother is at Emerge. He was doing his internship through Emerge at St. Paul's. Somebody even coming with a stubbed toe, and he wanted to be seen right away. He said, "I'm sorry, but I've got somebody with a stab wound here that I'm dealing with. That's going to have to wait, right?" So I wonder what the education, I don't know if you did any surveys or feedback from, if that was something that was a metric that was, followed through this process.
It's kind of interesting. There's been some kind of unexpected learning. So, at the height of the pandemic, there was an incredible amount of anxiety, especially, around whether they should approach the emergency room. This was when, vaccination was low. There was a lot of unknowns. Delta was circulating. And what we found is actually people are using the platform, and we were actually encouraging those patients to go to the emergency room because that's where they needed to be. Because, so to a certain extent, patients were staying home instead of going to the emergency room, even though that's where they actually needed to get their care adjudicated because they were fearful. So ironically, for about 5% of patients, we're like, no, actually the emergency room is safe. That's where we need to go. We're going to let them know you're on your way. Here are the precautions that are going to be undertaken to look after you. So it's kind of like paradoxical, you had really, really sick patients that really needed to go, but they didn't want to. And we were kind of making sure that they got to the most appropriate care they needed. Conversely, what I think has really been interesting about this, and what I share with government all the time, is that it's not that we have 280,000 charts or whatever the numbers are. It's or close to. I said you have 280,000 citizens that trust getting healthcare digitally. They actually, I said this was the fundamental problem when I first started eVisitNB. People were skeptical. This was pre-pandemic. People were like, I'm not sure. Could this really meet my needs? Is this really efficient? Is it worth my tax dollars or me personally paying for it? So how do we leverage what I call digital health 1.0, which is people actually trusting, care in the palm of their hand. And then how do we leverage that trust? How do we start, instead of a transactional relationship? How do we get into a conversational relationship around health? Because it's not a one-way device. Getting care on your phone means that you can now get education on your phone. You can now get monitoring on your phone. You can now get medication compliance on your phone. And you're engaging with healthcare on your phone. And if you leverage that trust and start making it about engagement, maybe we can start using it to drive outcomes that really matter, which is making sure we have a healthy population at a good weight with good diabetic control, with appropriate nutrition, good cancer screening. Really look at leveraging this digital trust and recognizing that the episodic care that we've been providing is an opportunity to just build an entire ecosystem around our citizens and make sure they're getting everything they need, from screening to medication management, to nutrition advice, to episodic care, to chronic disease management, right in the palm of their hand. And that's what I'm super excited about, is where are we going next? But I think that, this story is just beginning. And what I like about the fact that this might be happening in Saskatchewan is that this episodic care, this trust, this digitization of data, the deep learning that you'll get from it, and then of course leveraging that trust of your hundreds of thousands of citizens, and then engaging them in a conversation around their healthcare and helping them optimize their well-being with whatever you create right in the palm of their hand, which is what I think the future is. So, what does health, that's the big story for me.
Yeah, and I think one of the things that I shared with Tom and the minister earlier this week was, our focus is on preventative, predictive, participatory, personalized.
Yeah,
and
there you go.
what those 4 Ps do is you need the assumption behind that is that you have the data to be able to let's just say push notifications to the right person for the things that they do. So, when I start searching for river barge cruises, my phone starts to tell me all of the deals, and the YouTube starts to give me the algorithms start to work, and all of a sudden these magically, or the phone was listening to a conversation, and all of a sudden a certain tool appears because I was looking for a miter saw. A deal. So I think the focus on prevention, because I said I was asking my brother as a surgeon, I said, will you ever have a lack of supply of patients for surgery? He said, no. So he said, even if we expanded the surgical theaters, just like having a second, third fridge, it will be full.
Mm-hmm.
Said, yes. So we have to get to the root of the problem, which is getting the people involved in a better, let's just say the longevity medicine, lifestyle medicine, which is looking at, I heard the curriculum down in the States, which was called Eat Well, Move More, Less Stress, Love More. And it's taking control over their own health as much as possible, so that the life that you do live is as high quality and sick free the longer that you are. And I think this type of a service has the ingredients of that data collection that can help educate for the the citizens to take it upon themselves, to those who can, right? Because there's also socioeconomic issues that prevent others, because you're getting into mental health addictions, homelessness, and some of those social determinants of health that has to be addressed by policy. But at least you get as many managing their chronic disease better, knowing, because there's talking to endometriosis patient, by the way, Hanif and Tom, was she said, she made a very interesting comment. She goes, why is it that all the snake oil solutions are really good at search engine optimization and appear on the first page of Google, and you guys that do peer-reviewed publications are buried? And I said, well, there's something called regulations, the FDA. We can't make claims until the FDA has given their stamp. So it's a ability to give accurate information that is relevant to the person based on their profile, that they can act upon. And I think that's where you're heading. This would maybe AI and ML can help to create some additional data sets that start to improve, outcomes and put an emphasis on the front end of prevention and prediction of what may happen. So anyway, Tom, I know you were going to say something there. Sorry about that.
Oh, I was just going to say that right there, Sanj, is the essence of this slow, painful lesson that healthcare has to learn. Like the only way to make healthcare more efficient, you got to put the health back in. Your freezer example is so bang on. You buy another freezer, what do? Fill it. You create more surgical capacity. What's going to happen? As long as we keep living this way, it's not going to change. And it's funny because like you can go back and watch YouTube videos of Tommy Douglas speaking in 1978 and getting up on stage and saying Medicare will, suffer a slow death by strangulation if we don't focus on preventative medicine. It'll become so untenable if we can't do this right. And for so long, we've just been stuck in this really transactional, like 5 minutes, I'll just give you a pill. But this new way of having this digital first or digital access, it lets so many other collaborators get in. Like you've got NPs in there today, Hanif, you've got the medical directors on top of that, but the care team can expand so much. Like I see programs in virtual care. Have you guys heard of Brendan Burney's company, Lifestyle RX out of BC as an example?
I have not.
Okay, quick anecdote, but this is so cool for virtual care. So he's one of those specialized clinics. Brendan had he had a wellness clinic. He's a doctor, had a wellness clinic in BC, and the pandemic basically shut it down. Nobody was coming into the clinic, but he had all these diabetes patients. And so he said, well, let's go virtual. Let's do a diabetes health program virtually. And what he did was there's a dietitian on the platform. There's a couple MDs that supervise. One of the docs we work with at Lumeca works with them. So they supervise the patient's lab results and whatnot. And they got nurses managing the patient, and they coach these patients. They're all type 2. They coach these patients on their diet and their lifestyle and their blood tests and their blood results. And 70% of these people are getting off their insulin, these type 2 diabetics. Like that's the virtual care of the future, like that's where you take exactly what you're talking about, Sanj, and exactly what you've got with the care team ability, Hanif. Like that's where we go from here to put the health 100%. Back in.
And what I really get excited about is that, we're at the beginning, right? So I think that a lot of people assume that we're at the end. So when I get into conversations about digital health, they're like, they assume that this is, I try to say, this is just the beginning, like literally this is like a Samsung, this is like that Motorola Razr flip phone, right? This is not your iPhone 15. Like this is not the end. And I think, I don't know what it is about healthcare, but whatever solution you have to bring forward today has to be perfect, even if the existing solution is horrible. So it's really bizarre. I call it the innovation gap. Like, whatever you want to replace an antiquated or legacy system with, you can't unless the system you're replacing it with is perfect. But, so you just keep using the same old stuff because nothing's going to be perfect. And that's why I think we're stuck in healthcare. But so I think that's really important to emphasize is that what you see today is the beginning. And if we're left to flourish and innovate and drive real value and really kind of focus on outcomes there that matter, like you've talked about, which is, how do we live longer, better, richer lives full of less stress, more love, more mobility. I think we can get there, but I think that we can't do that until we quantify ourselves, until we digitize our health. You can't have your entire healthcare locked away in a paper chart in your family doctor's office for the last 40 years and expect to have, our cars drive better today because we download the data every 8,000 kilometers and your technologist and mechanic make small changes so that, 106, I can't replace my RAV4. I want to. I really want a new car, but it's a 2019 RAV4. I have 4 kids. I've got 237,000 kilometers on it, which is a lot. I drive rural roads, and you know what? The bloody thing still drives like new because I keep taking it in every 8,000 kilometers, and they plug it into a computer, and they make small changes, and I think that thing's going to outlast me. Kids are going to inherit cars because the amount of data and iterations that we kind of, are able to do, these things never break down. They're not your mom and dad's car. They don't have smoke coming out. They're not being towed in. You don't see them by the side of the road with the hood up. They're not dismantled on the front yard like they used to be when you were out with your grandpa. Literally, we've quantified cars, and hundreds of thousands of kilometers later, they drive like new. And yet your health history is in a paper chart in a doctor's office. And you wonder why you feel so crappy at 58, when you should really feel 28 if we actually were able to optimize your health and well-being. And digital health 1.0, 2.0, 3.0, 4.0, I think finally, I want to be 75 and feel like I'm 45, but I'm not going to get there unless somebody can figure out what's wrong with me early before I'm even feeling it and fix it. And I think digital health is going to allow us to get there. That's blue sky. Today, we need to make sure that, citizens get access to basic healthcare, that they trust and, the devices that they have in their hands, that they're able to get their needs met. And then people like yourselves who are thinking about, how do we build a better future and bring it today, can use this technology that people are trusting and deploy strategies and innovation to make them live longer. So I think that this is the beginning, which is what I keep telling everyone. So, we can't squander this opportunity of digital literacy and digital. If we do, we won't even get the opportunity to get started, and we're right back to where we were pre-pandemic, which would be a real shame. So maybe that's not a bad place to kind of leave what I think the vision of digital health is for the future.
Yeah, I think on that note, I don't think an encapsulation is required. I think that's perfectly said, Hanif. I want to thank you for taking the time today to share your thoughts, what you've done in New Brunswick, and Tom, for your passion and championing the bridge, bringing that digitized opportunity to Saskatchewan. I know it's been a tough challenge, but at the same time, I think the timing is right, and we're here as the Office of Health Innovation and Economic Development as well, and our partners to help support that and champion that. And of course, we have our own personally have a clinic that we can already is set up as a nurse practitioner clinic, which I think could be expanded for this 660,000 square kilometer province, which is almost 9 times the size of New Brunswick, which I think the digital health will even be more amenable for our citizens here. Tom, any last thoughts from you before we wrap up today? And by the way, we're not sponsored by Toyota, just so you know. Yeah. but a sponsor that we should go to and see if the RAV4 people would like to do that episode. Anyway, yeah. But Tom, go ahead.
I was gonna say don't pick on New Brunswick too much. Hanif's got to deal with 2 health authorities over there in 2 official languages. Just because we got more square kilometers, it's not always apples to apples. But no, thank you, Sanj. Thanks, Hanif. Great to talk to you guys.
Yeah, thank you again.